Welcome all of you to this live program, Orthopedic Principles. Today, our guest of honor is Dr. Abhinav Gulihar from London, United Kingdom. Dr. Gulihar received his medical qualification in 2003 from the Kasturba Medical College in Bangalore, India. Afterwards, he completed specialist orthopedic training in East Midlands and Kent, Surrey, and Sussex before going to do a fellowship at the Southwest London Elective Orthopedic Centre and also undertaking a European Arthroscopic Fellowship. To further his specialist training, Mr. Gulihar took the opportunity to learn from several experts in shoulder surgery during visits to Europe and the US. Notably, Mr. Gulihar completed 2 research degrees, a master's in orthopedic engineering and an MD in joint cartilage research from the University of Leicester. So today is my great honor to introduce you to Mr. Abhinav Gulihar from London, United Kingdom. Over to you, Abhi.
Excellent. Well, many thanks, Hitesh. Thank you for inviting me to give this talk. And thanks for the introduction. So as you said, I work both in the private sector and the National Health Service, and my main NHS practice is at King's College Hospital. The talk I'm giving today is about the long head of biceps. It's one of those structures that can sometimes get ignored when you're assessing a shoulder pathology. And my preferred operation is a tenodesis, which I perform arthroscopically. So we'll have a brief chat about that towards the end of the talk. In terms of anatomy, so the anatomy of the long head of biceps has been well described. We know that the long head of biceps attaches to the top of the glenoid along the supraglenoid tubercle, but actually it merges with the superior labrum completely. The intra-articular portion of the tendon is a bit flat and slightly wider, but the extra-articular portion, because it runs through the bicipital groove, it is slightly narrower and round, and therefore it is able to glide in and out of the bicipital groove during motion. So when we talk about the long head of biceps, it is very important to understand the role of the biceps pulley. So on the left-hand image here, which is marked as A, we have a structure which is holding the biceps tendon in place. Now this is called the biceps pulley, and it is simply an extension of the superior glenohumeral ligament. The role of the pulley is extremely important because without this, the biceps is not stable in its groove. The image marked B shows what happens under lateral aspect of the long head of biceps. So the structure that you can see here merging with the humeral head is the supraspinatus tendon. So on the left hand side, which is image A, we have the subscapularis and the biceps pulley, and on the right hand side, on the lateral side, we have the supraspinatus. So these are the boundaries on either side. Now the roof of the bicipital groove is formed by fibers that come from the coracohumeral ligament. So all of these structures play an important role in keeping the biceps where it is, and also to allow friction-free movement when the shoulder moves as such. So the image on the top right is basically the image of a left shoulder arthroscopically. So the SCP is subscapularis, SGHL is the pulley, which is a continuation of the superior glenohumeral ligament. CHL is coracohumeral ligament fibers, which help to form the transverse fibers of the bicipital groove. And then you've got the long head of biceps and the humeral head. The image at the bottom simply represents a right shoulder. So in terms of what pathologies can affect the long head of biceps, and therefore what are the indications of an arthroscopic biceps tenodesis, we have the familiar surgical sieves. So you have degenerative conditions or inflammatory conditions, and they're often interlinked. So it's when the biceps tendon, for example, has been inflamed over a long time, it leads to degeneration and delamination, or alternatively, if it is degenerative, then there can be associated inflammation causing pain. So tendinosis of the biceps tendon, and more commonly, irritation of the biceps due to tendinosis of the adjacent supraspinatus tendon are extremely common. A SLAP lesion or a superior labrum anteroposterior lesion where the superior labrum has been detached from the glenoid can both be traumatic as well as degenerative. And when it is degenerative, often it is asymptomatic. So we only need to treat the symptomatic ones. There can be mechanical problems with the biceps, or you can get instability. So mechanical problem uh, can just be rubbing of the biceps against the humeral head, and that is commonly seen in rotator cuff tears. Rotator cuff tears also lead to biceps instability. So if we go back to the image on the previous page, if we look at image A, in case of a subscapularis tear, that upper subscapularis, the biceps pulley is often damaged, and this leads to medial subluxation of the biceps tendon, and sometimes it's completely dislocated within the shoulder joint. And image on the B, if there is a supraspinatus tear, there can often be micro motion of the biceps. And sometimes when we go in for an arthroscopy in these cases, the biceps has already caused damage to the cartilage of the humeral head. And finally, the traumatic conditions purely of the long head of biceps. So there can be partial ruptures either due to sudden trauma or due to uh, multiple small minor episodes of trauma. And that can easily lead to a full thickness rupture. And finally, as I said before, slap lesions can often be traumatic and be painful as well. So tendinosis of the biceps, so just like any tendon, biceps has got a synovial sheath, and therefore the synovial sheath can get inflamed. Now, when the tendon is inflamed, it is swollen and therefore increased in size, and it has a constrained path within the bicipital groove, which can then lead to friction, worsening of inflammation, more pain. And as it is adjacent to the supraspinatus insertion, impingement syndrome or inflammation of the supraspinatus anterior edge often causes inflammation of the long head of biceps. Now, with time, the inflammation leads to hypertrophy, and then there is fibrillation of the tendons. So in the bottom right image, you can see there's been damage over time and the tendon has been delaminated. And this is not something that happens overnight. This happens over usually months or years due to tendinosis. The rupture of the biceps tendon, extremely common condition. So the image on the right is an arthroscopic image of a patient who had biceps pain, positive biceps test, but normal MRI arthrogram and normal plain MRI. So we were told there's no problem with the MRI. Inserted a camera in the shoulder, and here we see that the biceps is literally hanging by a thread. So this was a degenerative tear of the biceps, which had been exacerbated by recent lifting. Now, sometimes in a case where the biceps is already degenerate or torn, and patients are lifting something, the biceps can tear completely. And in that scenario, they would feel a pop or they would feel something give. And sometimes you can get a Popeye sign in these patients. So in general, the tearing of the biceps actually takes the pain away, and very rarely something is required unless they have cramping pain. Once the biceps has already ruptured, then an arthroscopic biceps tenodesis usually cannot be performed. So arthroscopic tenodesis is usually reserved for almost intact biceps without significant tearing. So we talked about medial instability earlier. So image on the left shows that the upper subscapularis is torn. As a result, the pulley is degenerate and torn as well. So in such a scenario, there can be micro motion of the biceps during movement of the shoulder. Now in the bottom left image, the subscapularis has completely been torn, and hence the biceps tendon is seen outside of the groove sitting within the glenohumeral joint. So that is the common medial instability. Sometimes you can have medial instability, but it is superficial to the subscap. So it's outside the subscap. That happens when the transverse ligament, which keeps the biceps within the bicipital groove, is injured. And I have had at least 2 patients that I can think of where we were expecting to see a subscap tear, but MRI showed the actual tendon is sitting outside the shoulder. So we had to do a bicep tenodesis for these 2, and we had excellent results. Lateral instability is usually caused by tear of the coracohumeral ligament, or more commonly the supraspinatus. Now, the biceps very rarely dislocates, but as I said earlier, this can cause damage to the humeral head by constant micromotion and lateral movement of the biceps. And if we are going to fix the rotator cuff tear, often you have to address the biceps as well. Slap lesions. So basically, detachment of the superior labrum, as we discussed before, can be both degenerative and traumatic. Either way, that doesn't mean that it needs an operation. Now, slap lesion, there are multiple types described, and I really don't bother trying to remember all of these because you don't need to. The bottom line is, if they are symptomatic, then you can try injections or surgery. If they are asymptomatic, then regardless of the type of tear, it is very unlikely that we will go and intervene. So these are a couple of arthroscopic images showing a slap lesion. And the type 2 slap lesion is the most common. Type 2 is when only the superior labrum is detached without any extension into the long head of biceps, without any extension anteriorly into the labrum, and without any significant posterior extension. On the left-hand image is what we see commonly, is that the biceps is very gently elevated and other parts of the labrum are generally quite stable. But in the right-hand image, what we are seeing is an extensive superior labrum tear extending both posteriorly and anteriorly. And obviously in patients with significant symptoms, you would have to do something about the labral tearing as well. So how do I clinically assess whether there is associated biceps pain when there is, for example, subacromial pain in patients, or when there is just isolated biceps injury or pain? So when you take a history in somebody with shoulder pain, the very clear question to be asked is simply, do you have biceps pain? If you don't ask that question, often patients do not volunteer the information. They might say, yes, the pain shoots along the front of the arm, right down to the elbow and just beyond. But otherwise, you have to ask that question, do you have biceps pain in the front of the shoulder and sometimes in the biceps muscle itself? Sometimes, especially with biceps instability, they would have a clicking or popping sensation during certain movements. And those who are very fit and active, you would often find that when they do push-ups or bench press, as they go towards lifting the weight fully, they will feel that the biceps has clicked or there is a click in the shoulder. Now that click can be painful or it can be pain-free. And again, I would say if they are not painful, then it's best not to do anything at that time because you could potentially make them worse than they are. And sometimes there would be a clear history of trauma. So in addition to your regular shoulder history, it is important to ask these questions. And there are hundreds of tests described, as with any condition in orthopedics. So the most sensitive, in my opinion, is tenderness over the long head of biceps. Now, the way you check for tenderness is you ask them to hold their shoulder in a position of mild external rotation, about 10 degrees or so. And that delivers the long head of biceps towards the front of the shoulder. And you can often roll it easily under your fingers. And the key is not to push too hard, because if you push too hard, then even a normal tendon can be painful. Then I supplement my examination with special tests, Speed's test, Yergeson's and O'Brien's. Now, there are certain papers that would say if you cannot elevate more than 90 degrees, even passively, then the biceps could potentially be dislocated. Highly non-specific. Loss of terminal 10 to 20 degrees of elevation can happen if you have an hourglass biceps, which means that the internal intra-articular biceps is so hypertrophied that it has got an hourglass shape and it cannot escape the shoulder. So when you try and move your arm upwards, then it abuts against the labrum, the coracoid, and the cuff. Now, again, highly non-specific because a lot of people will have loss of terminal elevation. So these are images borrowed from the internet, and I apologize for not giving credit before. But basically, a Speed's test is performed in such a way, then you ask them to forward flex the arm up to about 60, 70 degrees. Then you ask them to push against resistance whilst palpating the tendon. Now, palpation of the tendon, I would say, adds a degree of accuracy and specificity to the test for sure. And it's very important to ask where the pain is. Jurgensen's test, uh, also a borrowed image, this is simply resisted biceps or resisted forearm supination. So as we know, the biceps is the major supinator of the forearm. So resisted supination whilst palpating the long head of biceps is an important test, but very rarely positive in long head of biceps pathology. I find it more useful for distal biceps pathology, but I do perform it every time. O'Brien's test, when there is pain against resisted elevation with the arm in an adducted and internally rotated position. So this theoretically is meant to cause irritation of the superior labrum or abutment of the superior labrum in this position. I would say that the test is important, but not always positive in labral pathology. So once I've performed a clinical assessment and I'm suspecting a problem with the long head of biceps, then I would consider further investigations. X-rays have very little role unless I'm suspecting osteoarthritis, but we generally get X-rays for most shoulder pain patients. We have had a couple of patients where loose bodies have escaped from the shoulder into the bicipital groove, and then we've had to go and fetch them and perform a tenodesis because the biceps are usually inflamed in such cases. So X-ray is useful in that scenario. Ultrasound can be performed, especially if we are planning to do a diagnostic or therapeutic injection into the bicipital sheath. It is useful for tendinitis, but doesn't really show any intra-articular biceps pathology. MRI scans are the most sensitive, especially with an arthrogram, which is very useful for a superior labral detachment or a slap lesion. And the gold standard simply is arthroscopy. Now, I showed the picture earlier where we inserted a camera into the shoulder, not expecting to see any biceps issues because the MR arthrogram was normal, but the biceps was literally hanging by a thread. So arthroscopy is the gold standard for sure. Non-operative treatment is something I almost always try unless there is major trauma to the rotator cuff and we're going to fix it anyways. So if there is tendinosis, then you can either treat the inflammation purely of the biceps, or you can also try and treat the inflammation of the rotator cuff, which will be basically a rehabilitation program focusing on the deltoid as well as the rotator cuff tendons. So we would start with the analgesic ladder, and if this has already been tried, then we would go down the physiotherapy route. Now, physiotherapy can be multiple forms. It can be exercise-based. It can be massage-based, acupuncture, shockwave therapy. So there are lots of various things that our local therapists can do. And I would say the success rate for physiotherapy in somebody with biceps pain and impingement is in excess of 50%. So it's definitely worth a try. Injections can be performed with or without guidance. They are equally effective, and they can be performed either in the subacromial space if we are suspecting impingement, or they can be performed within the bicipital sheath if we are suspecting tendinosis. And finally, if we are suspecting a slap lesion, they can be performed intra-articularly. So indications for surgery in my book are failure of non-operative management. So you've tried the steps from the previous slide and they still have a lot of biceps pain. If they have mechanical symptoms, so painful clicking and locking, and they are unable to move their shoulder through a full range of motion because of the pain or because of the clicking. If there is a traumatic lesion causing cuff tear, dislocation of the biceps, or if there is a traumatic slap lesion and they have already tried non-operative management. So trauma can be multiple forms and trauma can lead to multiple injuries. And it is not unusual to have to perform labral repairs and cuff repairs in the same patient along with a biceps tenodesis, or a slap repair and a cuff repair in the same patient, or a slap repair and labral repair in the same patient. So you have to consider all of these injuries together. Now, what is the alternative to a biceps tenotomy? Biceps tenodesis is you simply cut the biceps tendon. It is called as a biceps tenotomy, which involves detaching the long head of biceps from the glenoid anchor. This is an easy treatment. It is very commonly performed, isolated arthroscopic biceps tenotomy. Now, if you believe the publications, different papers would have different quotes. So between 40 to 70% risk of a Popeye type sign when the biceps is cosmetically not very nice. Some papers say up to 40% chance of cramp or fatigue when they have been using their biceps for a long time after tenotomy. I would say in my practice is about 10% with tenotomy, but then we do choose our patients selectively. And in in some patients, even if it's long head of biceps, but if they are very fit and active, there can be some loss of elbow movement and elbow strength as well. I have to say that's not common at all. So what is a tenodesis? Tenodesis simply means that we detach the long head of biceps from where it attaches to the top of the glenoid, and then we reattach it at a distal site. Tenodesis can be high or low, intraarticular or extraarticular. So these figures, again borrowed from the internet, show different areas and sites of tenodesis. So for example, image A is normal. Image B shows high bicipital groove tenodesis. And I've only had to do this when I am not expecting a biceps pathology. And when we go in there, you have a partial tear. So similar to the patient I showed earlier. And this is because we don't normally have the tenodesis screws. We would use the standard anchors for this. Now C is my preferred technique, so which is the lower part of the bicipital groove, and this can be done arthroscopically. It has got a learning curve, but we do get universally good results. D is similar to bicipital groove, can be done arthroscopically if you go too far down. Suprapectoral, I don't really see a major difference between C and D, and I usually aim to do a C rather than a D. Now, according to this picture, if you do it this level, it can change the shape of the arm, but that's not what we see. I think the shape of the arm can be adjusted wherever you do the tenodesis. And finally, probably the most common or the second most common is a subpectoral tenodesis, which is done through a mini open incision and is done just below the insertion of the pec major in front of the humerus. And it is documented that risk of pain at tenodesis site, especially if it's done in the bicipital groove, is as high as 10%, but usually it settles down. We always say to patients, it can take up to 12 months for full recovery so that they're not surprised when the pain is not better straight away. Again, some pictures just to show the various methods of tenodesis. So top left is my preferred method, which is done arthroscopically using a fork tip swivel lock anchor. And that's quite a straightforward procedure once you've gone through a few of these. The image on the top right is a screw tenodesis, which is done open in this case in the upper in the bicipital groove. Now this can also be done arthroscopically, and a number of units use a tenodesis screw for arthroscopic lower bicipital groove tenodesis. The two images at the bottom simply show a subpectoral biceps tenodesis performed through a 3 centimeter incision next to the axilla. So basically, you would identify the pec major, you would find the long head of biceps tendon, which has already either ruptured or has been divided using your arthroscopic approach, and then you would tenodese the long head of biceps, to the humerus. You can use a button or a screw, or you can use anchors. There are a number of various methods that can be used. So what are the pros and cons of a tenotomy versus tenodesis? We find that in tenotomy, the cosmetic appearance is usually well accepted, but you have to choose your patients carefully. Most patients don't have any weakness or cramp. So why do a tenodesis in the first place? We do the tenodesis usually in slim active patients who are unlikely to accept the appearance, and those who are very fit and active, and therefore they have a chance of developing biceps fatigue, biceps pain, and therefore reduced patient satisfaction. and definitely it's more commonly offered to men rather than females. Now, what happens in the biceps rupture? The vast majority are treated non-operative. Now, this is when the long head of biceps is already ruptured. It doesn't cause any effect on their function, but as we discussed, sometimes cramp, fatigue, cosmetic issues, and mild weakness. So in these patients, especially if they're very fit and active and they really want you to operate, then you can consider subpectoral tenodesis. How do we treat tendinosis or degeneration? So this is a bit of repetition. So the first scenario is you have rotator cuff pathology, but when you have done your arthroscopy, the long head of biceps is normal. If it's purely impingement, you can perform a subacromial decompression. And if there is a cuff tear, then you can perform a rotator cuff repair. The biceps can be left alone. But you would do a biceps stenotomy or a tenodesis when you go in there and they have an abnormal looking biceps, either hypertrophied, which has a partial tear, or there's a slap lesion. Okay, so again, it's a bit confusing, but you wouldn't consider a tenotomy or a tenodesis if they do not have any biceps symptoms. Okay, so this is for people who have got inflammation. You're going to do a subacromial decompression. But if you go in there and the biceps looks abnormal, you would only treat it if you have got positive history and examination before the operation. Large cuff tear, it is always worth doing something to the biceps because even after your repair, it is likely to be unstable. So dislocation or subluxation of the biceps, you treat the cuff pathology, which has caused the subluxation, and then you do a tenotomy or a tenodesis. Slap lesion, non-operative management, if there are no bicep symptoms, especially if it's degenerative. Traumatic patients, even with trauma, I would give a trial of non-op management almost always. And then you have to consider whether you repair the slap or you do a tenodesis. Multiple trials have now been conducted, or systematic reviews have been published comparing the two techniques. And the conclusions usually are either tenodesis is better, or slap is better, or there is no difference. So basically, the jury is still out there on this. My practice is, if it is an isolated slap lesion in a younger patient, let's say younger than 30, then I would do a slap repair. If it's an older patient, more than 30 years old, I would do a tenodesis. Final scenario, if they have got slap tear and a labral injury and they are young, then I would, when I say young, they could even be 35, 40. And if they have a circumferential labral injury, then initially I would repair everything before doing a tenodesis. So to summarize, biceps pain is often ignored and missed, but it is very common in rotator cuff pathology. So it is important to assess it properly, counsel the patient that there could be a biceps issue along with other issues, and you treat it appropriately. Trauma to the biceps, especially a traumatic slap lesion, does not mean surgery. They're often managed non-operatively. They do well sometimes without any treatment, and other times with maybe an injection and physiotherapy. Tenotomy is an excellent option for older, less active patients, but for younger, more active patients, tenodesis, again, a very good option. So whilst I conclude, I'll just run you through a couple of videos that show my surgical technique.
Abhi, do you find any difference between any of these techniques? Tenodesis, high in the groove, low in the groove, or subpectoral? Do you think pain perception is going to be different?
I don't think so.
No.
No, I think the aim of the treatment is to relieve the pressure from the biceps and basically get rid of that micro motion. For example, if you've got a staph lesion and it's causing pain due to shoulder movement, or if you've got a rotator cuff tear and the biceps is unstable. So whatever you do, whether it's a tenotomy, a tenodesis, or it's a slab repair, it hopefully will take care of the problem. And same way, wherever you tenodese, whether it's up in the groove, whether it's lower in the groove, or whether it's subpectoral, I think it works. And a lot of it is down to personal preference.
And Abhi, commonly biceps is known to be the pain generator, right? So do you think patients could have persistent pain after any of these procedures? And what is the difference? Is it you can still have pain with a tenotomy or tenodesis, persistent pain after surgery?
Persistent pain after surgery, as I said, is documented to be about 10%. Okay, but almost always, if you give it time, the pain settles down. So far, I have never had to go and revise a tenodesis. But if we have done a tenotomy, for example, then maybe once or twice we've had to go back in and do a subpectoral tenodesis.
And Abhi, what is of late trending among shoulder surgeons is usage of the long head of biceps as a superior capsular reconstruction in with a when you have a irreparable cuff tear. Interestingly, I hosted a surgeon who used to do a lot of muscle transfers, and the moment he started using the long head of biceps, he has reduced the number of muscle transfers. So do you think there's a huge potential for the long head of biceps as a superior capsular reconstruction?
Huge potential? No. I think it has a role, and it is not something I do at the moment, but we have looked at the evidence for sure. And I think it's too early. I think it's very early to say that its technique is going to work or not. And I personally would even hesitate a little bit trying to give a patient a general anesthetic just to stick their biceps into their humeral head. So once I see more long-term data, then I think it's something that we could try. But at this point in time, having done lots of arthroscopies, often the biceps, doesn't look very healthy. So to try and use that biceps for an SCR, to me, doesn't make sense.
Thank you, Abhi, for that. Abhi, just one more question before I introduce you to Loy. Abhi, see, a decade ago when Stephen Snyder came up with this classification types, initially I think it was only 5 or 6 tags and got extended to now I think 10 or 9 or 10. I mean, the surgical, everyone's talking about surgery, right? You do some form of surgery. But I think the last 4 or 5 years, the trend is to move away from surgery with respect to SLAP, is it?
Yeah, I think I agree. I think yes, when we were training, and I would say it's not last 4 or 5 years. It's been there for a while. When we were training, then yes, SLAP lesion usually meant go and repair the SLAP. But then obviously you got papers publishing that the SLAP often doesn't heal. You get persistent pain, and I personally have revised many SLAP repairs into tenodesis that have been referred to me for a second opinion. So yes, I think we now know that at least in the older patients, SLAP repairs are not a great operation. So people are moving away from it. But then they go up in peaks and troughs. So tenodesis is up and coming now, and a lot of people are now doing tenodesis more and more. So symptomatic SLAP, a lot of people, I agree, the trend is to try and manage it non-operatively. But if they don't work, then in older patients, a lot of people are just doing tenodesis.
Thank you, Abhi. Abhi, we are also joined by Loy. Loy Al-Khatib is an orthopedic surgeon specializing in shoulder surgery. He's based in Dubai, but now he's traveling. He's in Germany right now. Loy, we had Abhi with a beautiful presentation on arthroscopic biceps tenodesis. And Loy, welcome to the show.
Thanks for
Hi, Loy.
inviting me also, and thanks for accepting our invitation. Sorry, guys, I couldn't join you from the start. I was traveling. I just arrived at the hotel. Maybe one of the questions about SLAP for elderly patients, what do you do for them? Would you do just biceps tenotomy and leave the SLAP, repair it or not repair it? And how do you treat them postoperatively, such patients?
So a symptomatic SLAP lesion in elderly patients is quite rare in my practice. But let's say that you have got somebody with a
Let's define
SLAP.
elderly first. Let's define elderly first. What do you mean by elderly? Is there any age group, certain age group you are talking about?
I'm talking about, let's say, usually people older than 60, 65. We often find that they would have another pathology. Either it be subacromial impingement, or there would be ACJ arthritis, or there would be rotator cuff tears, which are obviously the most common. And in these patients, if they have symptoms of biceps or signs of biceps pain before an operation, I would obviously clinically assess them and examine them. And whilst I'm going to treat the cuff pathology, I would go and perform a biceps tenotomy in almost all of them. But let's say if you've got, somebody who's very fit and active, even in their 60s or 70s, and they are going to the gym, they're interested in maintaining their bicep strength and shape, then yes, we can consider doing a biceps tenodesis. But a slap repair at that age, in my practice, doesn't work. I think it has a high potential for non-healing. What are your views on it?
Yeah. Do you think that just repair or reattach part of it, I'm not talking about full repair, just will prevent the impingement of this slab tissue between the glenoid and humeral head, especially during the overhead activities? One of this can generate pain. And as well as these issues, as you said, they come with a cuff tear. And this cuff tear is not a complete cuff tear, even it's not a partial complete tear. It's not a partial tear. Sometimes this is a hidden tear, intertendinous. Do you have any tip how to identify this intertendinous tears, intra-op?
No, not really. I think if you've done an MRI and it shows you that there is an intratendinous tear, and let's say they have graded it as 50% of the thickness of the tendon, okay, then I would try and find that area with a needle intraoperatively. But let's say they say it's 20% of the thickness or 30% of the thickness of the tendon, then I don't think we need to do anything about it. I think that can be ignored. But the biceps, if it is painful, then again, I would do a tenodesis at that age.
Awesome, great. One of the studies done by Dr. Peter McDonald, he was my mentor during my fellowship in Canada. He did a study compared tenodesis versus tenotomy, biceps tenodesis versus biceps tenotomy, and they didn't find any difference. What do you think about this finding?
Completely agree. So I think tenodesis is often not required. And for me, the selection criteria for tenodesis are basically age, gender, and their level of function. So somebody who's aged, let's say, between 30 and 60, and they are male and they are quite active and go to the gym on a regular basis, then they are unlikely to accept a Popeye type deformity, and they're unlikely to accept a little bit of cramping pain when they're going to the gym. So such a patient is always better off, in my opinion, with a tenodesis. But on the other hand, if you've got somebody who's 55, they are not very fit, not very active, they've got biceps problem, then a tenotomy is a great idea. 5-minute operation takes the pain away.
I agree. Well, any thoughts on a transfer, the long head of biceps transfer? I did a fellowship with Dr. Kobiela. He was transferring the long head of biceps into the short one. What do you think about that?
I have no experience at all. And again, it's a bit like a tenodesis, isn't it? So what you're doing is tenodesing it in a non-anatomic site. Okay, so whilst it can work, and if somebody has got a published series or they have followed up the outcomes in a number of patients, then that's a reasonable thing to do. But in theory, it's non-anatomical, and it's basically a stitching a bit of soft tissue to another bit of soft tissue. So it's not necessarily as secure as tenodesing it to bone.
Totally agree.
But having said that, like I said, Carlos Kobiela is a very well-known surgeon, and if he's done hundreds of these with good results, then why not?
That's a good point. Hitesh, I think that's it.